It is a pleasure to be here, and I would first like to thank the organizers of the conference for providing me the scholarship and giving me the opportunity to share these results. So this analysis on entry into care following universal home-based HIV testing has been conducted within the ANRS TasP trial in South Africa that I will present you later. As you know, early linkage to HIV care and early IRT initiation further to an HIV diagnosis are crucial for ensuring the best health outcomes in HIV-infected individuals, and especially in reducing the risks of HIV-related morbidity and mortality, as recently shown in the Temprano and the START trials. It has also been shown that high adherence to IRT could prevent HIV transmission to uninfected people at individual level as well as populational level. The guidelines are thus to treat earlier towards the universal test and treat strategy. The majority of you know the 1990 target presented on this slide, established by UNAIDS in 2014 in accordance with the goal of the universal test and treat strategy. To achieve the 1990 goal, one of the crucial steps is a linkage to HIV care, on which I will focus in this presentation. The problem is that many individuals are lost to follow-up between HIV diagnosis and linkage to HIV and IRT care, as suggested by some literature reviews. Several HIV testing services are currently evaluated for increasing the number of people living with HIV knowing their HIV status. One of them is a home-based HIV counseling and testing that has been evaluated as acceptable and effective for increasing HIV testing coverage in regions with high HIV prevalence. However, limited data have explored properly linkage to care after an HIV diagnosis through home-based HIV counseling and testing. And among the studies conducted in South Africa, we observe large differences of proportions of linkage to care depending on the study population. The objectives of our studies were to describe the proportion of linkage to HIV care with instruments of referral following home-based HIV counseling and testing in a rural area of high HIV prevalence in South Africa in the context of the universal test and treat strategy, and to explore the factors associated with poor linkage to HIV care. We used data from the ANRS TasP trial, that is an ongoing cluster-randomised trial evaluating the feasibility, the acceptability, and the efficacy of immediate IRT and HIV incidence in rural KwaZulu-Natal. In this TasP trial, home-based HIV testing is offered every 6 months. Individuals identified HIV positive are encouraged to go to a TasP clinic where they are offered immediate IRT initiation in the intervention clusters or IRT according to the South African guidelines in the control clusters. HIV care is also available in the clinics of the local HIV program where people can receive IRT according to the South African guidelines. For this presentation, we will call these clinics DOH clinics. Only individuals aged 16 or above are eligible for trial participation. For this analysis, we included specifically those who were identified HIV positive during home-based HIV counseling and testing, who were referred to a TasP clinic from March 2012 to June 2014, and who were not actively in care at referral. That is to say, they did not visit the local HIV program within the past 13 months. We excluded individuals with inconsistent dates and those with a period of observation shorter than 3 months among those not linked to care. We also excluded individuals who died or migrated before linkage to HIV care within 3 months of referral. We then excluded individuals with incomplete data. The outcome was a linkage to HIV care within 3 months of referral. Linkage to care was defined as attending a TasP or a DOH clinic. Explanatory covariates were collected at referral before HIV identification. We included sociodemographic variables, HIV-related variables, or trial-related variables. To explore factors associated with linkage to HIV care within 3 months of referrals, we conducted a multivariable logistic regression. As you see on this flowchart, more than 2,500 individuals were identified HIV positive through the TasP trial. After exclusion, more than 1,300 individuals were identified as not in care at referral, as presented in the green box, and 1,218 individuals were at complete data and were thus included in our analysis, as you can see in the box on the bottom right. Among them, about 43% were newly diagnosed and 25% were already diagnosed but had never been in care. About 32% of individuals considered that not in care at referral were lost to follow-up. That is to say, they had already visited a DOH clinic, but more than 1 year before TasP referral, included half of them for more than 24 months. Here is a brief description of the study population with, in red, some key characteristics important to keep in mind. More than 41% of people were less than 29 years old, 45% among women and 32% among men. More than 35% of women and about 42% of men had an education level equal to primary school or less. More than 76% of women and 68% of men were unemployed or were not in school. And about 41% of women and 28% of men declared that they knew at least one HIV-positive family member. On this slide, you can see that the proportion of linkage to HIV care in a TasP or in a DOH clinic within 3 months of referral was relatively low, with about less than 40%, with no significant differences between men and women. Our results also showed that rates of linkage to care were not significantly different according to the randomized arm of the trial, which means whether people faced the prospect of immediate IRT or not. In these slides, you can see the higher proportions of linkage to care in green and the lower proportions in red. We observe that in the multivariable model, the proportions of linkage to HIV care decreased with education level. This was only significant in women. We also showed that students were less likely to be linked to HIV care, but this association was not significant when stratified by sex. Another finding is that people who declared knowing at least one HIV-positive member and those who said that they would take IRVs if they were HIV-positive were more likely to be linked to care. Even if we see these tendencies in both men and women, the associations were significant only in women. Then, when looking at the trial-related characteristics, we can see that the proportions of linkage to HIV care decreased with distance to the closest TasP clinic, with an association significant only in women. Lastly, individuals who had never been in care within the DOH program were less likely to be linked to HIV care, and this association was significant in both sexes. In conclusion, we observe that less than 40% of HIV-infected individuals linked to HIV care within 3 months of referral after home-based HIV testing, with no differences between men and women. We also showed that linkage to HIV care was associated with socio-demographic characteristics, HIV-related characteristics, and trial characteristics. For men, the pattern of associations with linkage to HIV care were similar to those seen in women, but few reached statistical significance, probably because of a lack of statistical power. Further to this analysis of factors associated with linkage to HIV care, the researchers of the ANRS TasP trial are thinking about the implementation of several interventions in collaboration with the community to increase access to HIV care in those who are less likely to be linked to care. The first intervention that has already been evaluated as effective is the sending of text messages to all the individuals to remind them of clinic appointments. For those who missed linkage to care, we aim at proposing personalized counseling and motivational support with health system navigators. This support could firstly be offered by phone, then by face-to-face visits. Then, for those not linked to care after counseling and motivational support, we aim at proposing home-based IRT initiation on care with CD4 point of care. This could be a help for some individuals to access HIV care, especially those who live far away from the clinics or who may have difficulties to go to an HIV clinic. At the end, we aim at encouraging them to go to a clinic for their long-term follow-up. Before finishing the presentation, I will like to thank all the trial participants, the staff of the Africa Center in South Africa, the traditional and national authorities, our founders and sponsors, all the TasP Study Group, and once again the organizers of the conference. Thank you very much.
So we have about 4 minutes for questions. Yes, number 2, please.
Good afternoon. Julie Pullerwitz from Population Council. Thanks for a very nice presentation. My question is around stigma. I noticed that you included stigma in your model, if I understood correctly, on the bottom. Could you tell me a little bit about what kinds of stigma you were looking at, internalized, compounded, external, how you were measuring it, as well as what was the relationship between stigma and some of your outcomes?
Thank you for the question. So we had 2 questions for stigma about the perception of the community on HIV positive individuals. So do you think that people reject HIV infected individuals? And we included these variables in the model, but we didn't find association between stigma and linkage to HIV care.
So just a quick follow-up. If I understand correctly, you used one question, not any of the stigma scales that are out there. One question about your perception of stigma as experienced by people living with HIV. Is that right?
I'm not sure. One was about community, the perception of the 2 questions were about the perception of community. One was about do you think that people reject HIV infected people, and the other one I think was do you think that people avoid HIV infected people?
Thank you.
So, you're welcome.
Okay, next question, number 3, please.
Excellent presentation. I want to ask you, is this neutral space have a special characteristic, or you give an incentive to they come here?
Can you repeat the question?
You talk about neutral spaces to linkage healthcare. So I want to know if these neutral spaces has a special characteristics.
Did you understand it?
I'm sorry, can you say it one more time, quite slowly?
Okay. I want to know if these neutral spaces that you have mentioned.
The neutral space.
Okay, the intervention.
Neutral space.
Yeah.
Neutral spaces, you said? Okay,
d'accord.
want to know, go ahead.
Sorry, yeah, the question is if the neutral spaces have special characteristics.
Okay.
What characterizes the neutral spaces that are used before linkage?
What is species? What is species?
Neutral spaces.
Neutral spaces.
Yes.
Sorry.
Yeah.
We are currently writing the proposal for the intervention, so we are currently thinking about the neutral spaces, but we have not decided yet which one.
Thank you. Number 2, please.
Hi, thank you for a nice presentation. My question is just, and I might have misunderstood a little bit, but in terms of comparing the linkage of care in this model and the home-based testing model compared to linkage of care in people who are tested at Department of Health clinics, do you have any comparison in terms of linkage of care or percentage of linkage of care?
In the Comparison between what and what?
So comparison to your home-based model, like you said, the linkage to care was about 40%.
Yeah.
If you compare that to people from the same community who are being tested, who do VCT at the Department of Health clinics, how does that compare?
So it's difficult to answer because in the DOH clinic, so the clinic of the local program, HIV testing is directly inside the clinics. So it is a rapid HIV test, so people know the same day the HIV results, and the same day they have a CD4 count. So it's we can't really measure linkage to care within
Okay,
the.
like you don't know how many of them actually follow up.
No.
Number 3, please.
Yes, thanks for the interesting presentation. Jochen Emer, I work for Solidarme, the Swiss NGO supporting HIV care delivery in sub-Saharan Africa. Just to add that we conducted similar studies in Mozambique and Lesotho with very similar results. So that's already interesting. And I'm interested in how can you overcome, I mean, this missing linking into care. And you suggest here 3 interventions. And I would be interested, is that stepwise and especially related to the home-based ART initiation, which is something which seems obvious if you talk about test and treat and reaching the 90-90-90. Is that already implemented? Will it be implemented? And how will it be?
It's not implemented yet. And we are still writing the proposal for implementing it. So we are working with the committee and with the local authorities to see how we can implement them. So we are still working on the implementation of these interventions.
Thank you.